My name is Siobhan Ray, and today I will be covering pedophilic disorder in the DSM-5. An overview of this disorder is that it is one of 8 paraphilic disorders in the DSM. A paraphilic disorder is characterized by persistent and intense atypical sexual arousal patterns, as well as clinically significant distress or impairment. The other 7 are listed below. This diagnosis has evolved over the last few editions of the DSM due to changes in sexual norms. The DSM-5 made a large change by adding the distress or impairment prong. The word pedophilia is derived from the Greek pediktos, meaning child, and philia, meaning love. The term pedophile is an unofficial legal term, not diagnostic. It refers to someone that has acted on these impulses rather than someone who just experiences these impulses. The diagnostic criteria in the DSM-5 is that that over a period of at least 6 months, there have been recurrent, intense, sexually arousing fantasies, sexual urges, or behaviors involving sexual activity with a prepubescent child or children, generally age 13 years or younger. B, the individual has acted on these sexual urges, or the sexual urges or fantasies cause marked distress or interpersonal difficulty. C, the individual is at least age 16 years and at least 5 years older than the children or child in criterion A. Note that this diagnosis does not include individuals in late adolescence involved in an ongoing relationship with a 12 or 13-year-old. There are multiple specifiers for this diagnosis. First, you must specify if it is exclusive type, meaning they are attracted only to children, non-exclusive type. You have to specify if the individual is attracted to males, females, or both, and you have to specify if this is limited to incest. The prevalence is fairly unknown. Most individuals with pedophilic disorder do not seek treatment, and they come to light through the legal system. Estimates, the most cited prevalence estimate is 3 to 5% of males, but these estimates are based on small unrepresentative samples, meaning these are the individuals that have come through the legal system and does not include individuals who just have these urges but have never acted on them. Some studies of sexuality among large populations do show a higher prevalence of these thoughts and fantasies, but not to the point of meeting the diagnostic criteria for pedophilic disorder. It is estimated to be the most common paraphilic disorder of the 8, and in the past it was believed that it only existed in males. But that's not true. There are cases of females in the literature, but it is rare. You may think of some of the cases of student-teacher relationships and things like that, but again, those usually hit the news because it is so rare. Comorbidity of this disorder, there have not been many studies differentiating between pedophilic sex offenders and other sex offenders. Most studies focus on an entire population of sex offenders. But Raymond in 1999 did a study of 45 pedophilic sex offenders and found that mood disorders were present in 67% of them, anxiety disorders 64%, substance use disorders 60%, and another paraphilia disorder 53%. There are very high comorbidity rates with depression, anxiety, and low self-esteem. but we are not sure if this is comorbid or a reflection of their disorder and their legal status, as most of these populations studied are in jail or prison. The course and prognosis of this disorder is largely unknown. The average onset appears to be during or after puberty, and according to Abel in 1993, the average age of onset was about 21.6 years old. The disorder is considered to be chronic, and the prognosis is not good. There are not many treatments that have proven extremely effective, and in some cases, the disorder may increase in severity. Cultural considerations are very important when it comes to pedophilic disorder. There, for years, has been disagreement across cultures of age of consent. For example, high-status males in South Afghanistan still participate in pedophilic practices with young males. In many primitive cultures, there are ceremonies celebrating puberty. In New Guinea and Melanesia, adult minor relationships to induce the onset of puberty are common. However, this is not allowed outside of this purpose. Because of this, communication is important to ensure that the individual you are treating meets the diagnosis and differs from their own societal norms. Pedophilic disorder was first described as a disorder in late the 1800s by Krafft-Ebing. The laws concerning age of consent have been around since Roman times, and evidence of prostitution of young males dates back to ancient Greece. However, severely punished if the young male had not hit puberty. Some researchers suggest that pedophilia is a human universal and is found across time and culture. The diagnostic criteria is not bound by cultural lines, however. For many, many years, the largest theory was that pedophilic disorder was caused by sexual abuse in childhood. However, Dewan and Marshall in 1996 found that only 50% of convicted child molesters were victims of childhood sexual abuse themselves. This is significant compared to the only 20% of non-sex offenders who experience sexual abuse. This proves that individuals who are child molesters are more likely to have undergone sexual abuse in childhood. But this population does not include individuals with the disorder who have not acted on their thoughts and impulses. Again, an underlying theme in research on pedophilic disorder. This theory of sexual abuse in childhood also does not explain the vast majority of individuals who have suffered child sexual abuse and never suffered from pedophilic disorder or went on to have those thoughts and urges. Another common theory in the past was learning theories that operant and classical conditioning led to the sexualization of children in certain individuals. However, this theory better explains other paraphilias, such as sadism and masochism, rather than pedophilic disorder. These theories are all fading out in favor of more biological theories. The current literature and current theories seem to most align with the thought that neurological abnormalities seem to be the main cause. The largest study by Cantor in 2008 used MRI imaging to find that individuals with pedophilia seem to have deficiencies of cerebral white matter. In other studies by Cantor, pedophilic men showed lower IQs, poorer verbal and visual memory skills, higher rates of head injuries in childhood that caused unconsciousness, higher rates of being placed in special education programs, and higher rates of failing grades in school. This seems to align with the idea that there is a deficiency in cerebral white matter, which would also cause the above listed situations. In 2002, Casanova published a study of 2 individuals post-mortem with pedophilic disorders and found abnormalities in the hippocampus. Another widely known study was back in 2003 when a 40-year-old male suffering from a right orbitofrontal tumor began exhibiting impulsivity and pedophilic thoughts and urges. He had never suffered from these before, and it appeared that they disappeared after the tumor was removed. Self-report measures are widely relied upon for the assessment of pedophilic disorder. 2 assessments that exist are the Clark Sexual History Questionnaire for males and the Multiphasic Sex Inventory. However, these have a low reliability and validity as it's easy to lie. Clinical interviewing is also widely used. Psychophysiological assessment techniques include phallometric assessment. This consists of measuring change in length and circumference of penis while exposed to stimuli that violate social norms. This is the most reliable and valid method available. However, it is not standardized, and there are certainly ethical concerns that go along with it. The differential diagnosis of this disorder is important. The most important phrasing in the diagnostic criteria is recurrent sexual fantasies lasting 6 months. Someone that has had sex with a child does not necessarily have pedophilic disorder. This could be due to substance abuse or extreme violence. It's important to rule out conduct disorders and antisocial personality disorders, especially in an isolated incident of sexual deviancy. Pharmacological treatment is the most relied upon treatment for pedophilic disorder. The goal is to reduce sex drive. Anti-androgens are used, which block testosterone's reaction in the body. It's offered in shot form that can last up to 3 months, and this is mostly known because of its use in hormone replacement therapy and prostate cancers. SSRIs can also be used to decrease libido. A recent study of 30 men treated with triptorelin and psychotherapy showed that for 8 to 42 months while receiving this treatment, and then extended to 15 years, no one reoffended. Triptorelin is a central hormonal agent and targets pituitary regulation to inhibit production of testosterone. The same authors came out in 1998 finding that these men reported fewer paraphilic sexual fantasies, lower frequency of masturbation, few incidents of abnormal sexual behavior, and no sexual offenses against children as reported by the participants, their relatives, and probation officers. There's no known cure for pedophilic disorder, and findings are mixed about psychotherapy. CBT is the therapy of choice for this disorder because it may help individuals cope with their urges and cognitive restructuring, self-control, and empathy. It might also help with coping with the side effects of these medications they may be using. Behavioral modifications through aversion techniques and satiation may also be helpful. A typical case presentation of this disorder follows. Jason is a 23-year-old male that has been referred to you through the correctional system. He was arrested after he attempted sexual acts with his neighbor's 9-year-old son. He has no history of substance use and no legal history. He reports to you that he had one girlfriend in middle school but has not dated since. He experienced sexual abuse by a piano teacher from ages 6 to 10. Over the past 2 years, he reports increasingly intrusive thoughts and sexual fantasies of young boys. He reports that he has a difficult time focusing and being productive because of these thoughts. In this case, it would be important to rule out conduct disorder or antisocial disorder. However, it seems that he has no legal history to indicate this. Additionally, he was not under the influence of substances, and he has been experiencing these thoughts over the past 2 years.